been looking at the medical problems of headaches and back pain because they are so common.
Right.
Um, and one thing I learned to appreciate too, when you were describing the role of the anesthesiologist, I thought, oh my goodness, it is so much more complicated than I ever imagined. So I mentioned to a friend of mine who was retired. He was a doctor of ear, nose, and throat, and he wants to read your book. But he also mentioned how the role of the anesthesiologist now is very sophisticated.
Yes.
So
Yes.
you mentioned that, for example, it's chest surgery. And you mentioned that anesthesiology for these kind of patients is complex and demanding. So, for example, you're working on the patient and you're telling the patient, if you need more sedation, don't hesitate to ask for it.
Right.
So many times in your book, you tell us as patients, ask for
Right.
what you need.
Right. But you have to know what's available.
Exactly. For example, if
Yeah.
I were going in, I wouldn't know if and when I would talk to the anesthesiologist. I maybe meet the surgeon, but it didn't occur to me that I need to see the anesthesiologist. And I think in the past you said you would see a patient maybe a week before the surgery, that 2 weeks were even better to meet with the anesthesiologist before surgery.
Correct.
What is typical today? Does the
What you,
patient meet with the anesthesiologist?
yes, I think we have pre-admission testing clinics, and we ask patients to come into that clinic so they can be seen by a nurse practitioner as well as a physician assistant. And if they're a, a risk, a high anesthetic risk, and they'll be seen by the anesthesiologist like a week or two before. And in that way, you have time to diagnose if they have undocumented hypertension or if they've developed asthma or if they have high blood pressure. There's a lot of things that you can look at in the pre-admission testing unit, and then you can correct it. If the blood pressure is too high to be safe for anesthesia, you cancel. You say, well, we can't do this until your blood pressure is within normal limits. So there's lots of reasons why we should see the patient in the pre-admission testing clinic.
Well, for example, you recommend to your patient avoiding ibuprofen and aspirin 2 weeks before surgery. And somebody who takes that, it wouldn't occur to them to perhaps mention it to the anesthesiologist. But you tell them, if you have been taking ibuprofen and aspirin, tell the anesthesiologist that. And I think
Right. It's
that's, mhm.
very important, especially if you're going to use a regional anesthetic, a spinal or an epidural, because then you can have a hematoma that might compress the nerve and cause more damage.
And we think of ibuprofen and aspirin as being healthy habits to take that, and it wouldn't occur to them to mention that to their anesthesiologist. Another thing that might not, well, I'll ask you um, about donating blood before the surgery in case the patient needs it. So, do you recommend that?
Oh, I think that's really important because if you get bank blood, there's all kinds of things you potentially could be exposed to. So if you have your own blood stored for you, give it like 2 weeks before the surgery, and you have it stored, then they can give your own blood back to you, so you won't be getting any unknown viruses or any other infectious diseases or having any reactions to the type of the blood that you're getting. So it's much safer. It's particularly important for uh, spinal surgery, spinal stenosis, and spinal, where we do 5 or 6 levels of spinal fusion for very bad backs, like in ankylosing spondylitis. So it's very important to know.
Well, it happens that I was reading your book. My brother had just had surgery on his foot, and so I had all sorts of questions for him. For example, why did he go to a larger hospital that was farther away than his local hospital? And he said the hospital he went to had 24 orthopedic surgeons on staff, and they did a lot of this kind of surgery that he was getting. And then I asked him, I said, well, did you donate blood beforehand. And he said, well, it really didn't involve that much possibility of blood loss, so he did not donate blood before his surgery. So,
Right. That wouldn't be.
so, but orthopedic surgery is one of the more common surgeries, is it not?
Oh, it is orthopedic surgery. We have in New York, there's the Hospital for Special Surgery that all it does is orthopedic surgery, and lots and lots of it. So they're really attuned to blocks and blood replacement and all kinds of things that might happen during the surgery. They have special anesthesiologists that are regional anesthesiologists and only do regional anesthesia. So it's very important.
Well, I never heard of cell salvaging. So,
Hmm.
should the patient ask, doctor, is cell salvaging available?
It is. All hospitals should have that. And it's particularly important in open heart surgery where a lot of blood is lost. So they need to save that blood and filter it and give it back to the patient so they won't have to have unknown blood.
Hmm. Well, what about blood pressure? What is the role of blood pressure? If you're an anesthesiologist, why would you be watching that?
Oh, the blood pressure. We try to keep you alive and safe during anesthesia and surgery. And blood pressure is very important because blood pressure uh, perfuses your vital organs during surgery. And if you're an elderly patient, say over 60, I know I hate to use that, but over six over 60, and your blood pressure goes down to 90, then you're not going to perfuse your brain, and you could wake up with cognitive dysfunction or personality changes. So blood pressure is very important to maintain during anesthesia and surgery, particularly in the young and the elderly, the extremes of age. But it's important for all patients because you never know when something's going to be triggered by low blood pressure. And you don't want high blood pressure either because you can stimulate the rupture of an aneurysm or a small vessel in the brain to rupture.
Well, another thing that maybe as the patient might need to decide, do I want regional anesthesia or general anesthesia? And how do I know which I want?
Well, I
Or
think,
maybe both.
right. Well, I think you can have regional anesthesia with conscious sedation. So you can be sedated and be easily awakened, but you won't remember much about what's going on. But I think regional anesthesia has recently come to be the anesthetic of choice in most orthopedic procedures because many of them take place in older patients and also in the very young if they're having a procedure that you can do a regional anesthetic on. If you use a general anesthetic in people over 60, again, some of the anesthetics cause, like fetal alcohol syndrome, the alcohol crosses the placenta. Well, the anesthetics cross and go into the brain as well. And if you have some neurons that aren't firing correctly, it might just push them over the edge and you lose some brain power. So if you're going to have a hip or a knee or any kind of surgery that you can have a regional anesthesia, you should have that, a spinal or an epidural.
My guest is anesthesiologist Dr. James Cottrell, and his book is Anesthesia Without Fear. Now, a few years ago, it didn't seem that long ago, somebody close to me had hip surgery and was in the hospital several days, was totally out of pain as soon as the hip was replaced. And then recently, a friend of mine had hip replacement. She went home that same day. I was shocked.
Hmm.
And apparently, this is becoming more and more common.
Oh, I think the regional anesthetic allows you to go home quickly because you haven't suppressed the respiration and haven't changed bodily function. You've just given a regional anesthetic, a block of the nerves. So when that wears off, you're free to go home. And they usually get you up walking on a staircase, an artificial staircase, so they can watch you walk just after surgery. It's just wonderful what's happened. And you can give a local anesthetic into the epidural that'll last for 24 hours, so the pain will go away.
Well, I knew that this person had hip replacement about 10 years ago, immediately there was a class, if you want to call it that, physical therapy right away. And so I asked this friend who had her hip replaced, I said, but if they sent you right home, what about physical therapy? And she said there was somebody who came to her house that did that.
Right. That a physical therapist comes and a nurse. Because many times when you have a joint replacement, have to be placed on blood thinners so you won't have emboli that go to your lungs. So then the nurse comes and pulls the bleeding time so that you can check that to make sure it's not too high or too low.
Well, I was amused at the first sentence, your chapter on ambulatory surgery. And I wondered, well, maybe you didn't realize the pun because you did have a collaborator. I'll mention that now, Dr. James Cottrell with Stephanie Golden. So maybe this was her pun. You start your chapter on ambulatory surgery. Let me walk you through a typical ambulatory surgery experience. So you can walk us through the ambulatory surgery experience. And this this is one thing I did enjoy about your book. You tell stories of somebody. In this case, there was a 54-year-old lady who named Arlene, and you tell her story about what her experience was. And it's helpful for us because then we can see it like a movie of what
Hmm.
the experience is
Sure.
like. And some of them just turn out just fine. But one lady really needed pain relief, and she kept being told no. And so finally, she called her health insurance, and they said, yeah, like, sure, no problem.
Right.
So I think it comes across with her story, be persistent. That when you ask for what you need, you say, don't hesitate to ask for it. But it sounds like sometimes you might need to be persistent.
Right. Because the managed care company doesn't want to keep you in the
Oh, yeah.
hospital or provide more care than you possibly can get away with. So if the anesthesiologist wants to give you an epidural for post-op pain relief and send you home with it, they could do that, but they have to get approval from the health insurance company to do that.
Mm-hmm. Mm-hmm.
Yeah.
After a break, Dr. Cottrell and I will be continuing our conversation about anesthesia without fear. You're listening to Nancy's Bookshelf on North State Public Radio. I'm Nancy Wiegman. I'm Nancy Wiegman, and you're listening to Nancy's Bookshelf on North State Public Radio. And I'm back with anesthesiologist Dr. James Cottrell, who has written a consumer's guide to safe surgery and chronic pain relief. On the subject of just keeping maybe preventative care, I didn't realize how
Hmm.
this is a colonoscopy now that I'm thinking about, that you say that people over 50 should get a colonoscopy every 2 to 4 years. My goodness. And they're not a pleasant procedure. Do you want to modify that, or do you stick by that recommendation?
Well, I think it depends on your family history. If you have a
Mm-hmm.
family history of colon cancer or someone in your family that's had polyps, if it were me, I'd get one every year. And then if they found one, then I may even get one every 6 months because it's so curable, colon cancer, and it's a shame to miss it. But now they're doing the blood test, the things that you send back into the office from your doctor, and if there's blood on that, if it's positive for blood, then they know that you need to come in for a colonoscopy to see if something's up there. But I think it's very important to get your colonoscopies done. It's like, people say mammograms aren't good for women over 55 or something, but now they're changing the recommendation on that. And PSA testing the same way for men for prostate cancer.
Yeah, the recommendations are constantly changing. You have to stay informed, and that's the subtitle of your book, The Informed
Right.
Consumer's Guide. So you want us to stay informed. I mentioned that these stories that you tell about a patient's experience I found helpful. Another thing that I found essential, really helpful, was your illustrations. And you might mention that you had a couple of illustrators. How did you work with them?
They actually were medical illustrators, so I could say what I needed, and then they'd send me a proposal for the drawing, and then I would just draw something else back on it if it wasn't there, and like the scopes or the laryngoscopes or the airway and stuff like that. And they were both very good. I
Oh,
have
yeah.
had two I worked with. They're both very good.
Their names were Tay McClellan and Megan Rojas, and I really studied those illustrations because I found them very helpful. And I mentioned
Oh, good.
you had a collaborator, Stephanie Golden, and how much of a role did she play when
Well,
she?
she's
Mhm.
she's a terrific editor, and since I was writing the book for the public, she was the public part of it. You could correct me if I was too complex.
Yeah, in fact, that's what I appreciated, that often if you used a word that we might not know, in parentheses right after that, you explained that word. And so I was thinking that likely would be her role to say, hey, doctor, those of us who aren't an anesthesiologist might not know what that is that you're just describing.
She was very good about that.
So
Yeah.
I appreciated her role, and like I say, the role of the illustrators in helping us to understand what you were saying.
Thank
So
you.
um, I would kind of like to go back over maybe some of the things that we said. For example, you as an anesthesiologist, what did you do before a patient had surgery?
Well, I would try to see the patient before surgery and get a history of that patient. It's very important to get a history if they've had a previous anesthetic. I think I tell a story of one patient that we got a history of the patient, and she didn't tell us that she'd had difficulty with her airway, breathing during the surgery. And so when we got ready to control her airway, we had a lot of difficulty and thought we were going to lose her. So you got to really get all the information you can, and the patient has to tell you if they've had problems with anesthesia, if they drink a lot, if they use drugs like marijuana can cause blood pressure to go down and heart rate to go up. So there's all kinds of things that we need to know so we can be prepared for it and prevent damage from occurring. I mean, one person came in and had an allergy to a drug that was commonly used in anesthesia and didn't bother to tell us. And so he had an anaphylactic reaction, and we had to treat that on the table. So it was very difficult. So it's very important for every patient to tell everything they know about their medical history, and then try to get the anesthesiologist to tell them what's available.
And you also mentioned that the patient should tell you, even if it's illegal drugs, because the anesthesiologist needs to have a complete picture. And so the patient needs to tell, even if they're illegal drugs, or a patient may be taking herbs and think, oh, I'm taking herbs for my health. The doctor doesn't need to know that, but you do. What kind of
Yeah,
herb would you
absolutely.
need to watch out for example? It's just an
Well,
example.
the for the one that's used for depression, Gilco Balbo, I think it
Mm-hmm.
is.
Ginkgo biloba.
Yeah, yeah, that's it. That one will cause some interactions with the blood pressure and also can cause bleeding. So it's sort of like the aspirin and the ibuprofen. If you're taking it pre-op, it'll cause the platelets to malfunction.
Well, the title of your book, Anesthesia Without Fear. So, why might a patient be fearful? What are the dangers of surgery for a patient?
Well, one of the things I focus in my book, I mean, this is a little out there, but I say, ask the anesthesiologist if he's going to be present or she's going to be present during the entire procedure. And if he or she is not, is somebody going to be there who's who is as qualified as he is, a board certified anesthesiologist, because we've seen too many stories where anesthesiologists go out into the hallway to talk with somebody, and then while they're gone, something happens to the patient. So you got to sort of stress on the anesthesiologist, not that this happens often, but you got to stress to the anesthesiologist that you want them there. You're paying for his or her expertise, and you want them there in case something happens. You don't always need him or her, but you need him in case something happens. And when it happens, it can be devastating.
And that would not have occurred to me to ask if the anesthesiologist asked him directly if he would be there. I know a friend who was undergoing rather serious surgery, and this surgeon was so qualified, and I was so impressed with this surgeon that he consulted. But the patient said, "Doctor, will you be doing the surgery?" And there was kind of a
Right,
pause, and he said, "I'll be there." So I thought,
right.
oh, that's different from actually doing it. So now I know, ask my anesthesiologist, "Doctor, are you going to be there?"
Right. I think there was a story in the New York Times where an anesthesiologist had actually gone to a bank to make a deposit while he had left the patient on the table. So you really need to stress that you want them there, because you think well, they are. They're important. They keep you alive while everything else is going on that would kill you.
And even what's going on in the operating room. You tell a story where this anesthesiologist goes into the operating room and is chatting the doctors and nurses about dinner she had. And if the patient's overhearing this, think, "My goodness, what about me? Aren't I important that you're just chatting about dinner?" And his was a rather scary experience because he was aware of what was going on in the operating room.
Yes, awareness does occur with general anesthetics, and awareness can consist of just being feeling that you're being pushed around to actual cutting and pain on incision. So we have to try and keep the anesthetic level at an appropriate level. And we have a new monitor now that's called a BIS monitor, and it monitors your brain waves and tells you how deep you are or how light the patient is. And we can adjust accordingly, and that probably helps us avoid most of the people who are aware during anesthesia.
Yeah, as I read your descriptions, I saw, boy, the anesthesiologist has to be monitoring and adjusting constantly. Well, of course, depending on the surgery, but we also mentioned briefly that managed care presents a problem for a lot of people. It's difficult to negotiate managed care. So if you're a patient, how do you make sure you get what you want and you need before surgery? What should we ask for?
Well, you have to ask most people go to the business center before they go into the operating room, and they review their insurance plans. And you can say, does this cover everything that I'm going to need during this procedure, this operation, or this hospital stay? I think it's a little sophisticated to know if you're going to need an epidural at that point, or one of the other specialized blocks to go home with, or a pump to take home so you can actually push the button to get more pain relief for a day or two after you go home. So that would have to come up sometime once you get into the hospital, and the surgeon makes you aware, and the anesthesiologist, of what's going to go post-operatively.
Well, I have a friend who been retired now for 10 years, but he was an anesthesiologist for 37 years. And
Wow.
reading your book, I thought, oh my goodness, he has really seen the evolution of the science of anesthesia. So, just in a couple of words, what do we have to look forward to, the future of anesthesia, doctor?
Well, I think now the biggest things that we've gotten rid of would be nausea and vomiting and feeling bad after anesthesia. People no longer have that because we have newer drugs and techniques to do that with. We're also now trying to prevent memory loss. And I think that'll be perfected in the next few years so that older people won't get delirious and get cognitive dysfunction after surgery, and that pediatric patients, children, won't get behavioral abnormalities if they have surgery for a long period of time. I think we also might be able to get a way to give anesthesia that's either magnetic or electrically introduced. So that then would prevent any of the complications from anesthesia, or many of them.
Well, I appreciate your writing this book, a book we didn't even know we needed, perhaps. Even though we're not the one undergoing surgery, we have friends and family that it's likely in their future. And maybe
Right,
a surprise, I mean, an injury, a young person on a motorcycle, for example.
right.
So, Doctor, let me give the title of your book again. Anesthesia Without Fear, The Informed Consumer's Guide to Safe Surgery and Chronic Pain Relief.
And the website is anesthesiawithoutfear.com.
My guest has been Dr. James Cottrell.